ग्रुप में मैसेज भी भेज दीजिए। हाँ जी। बार बार वो दर्शक। So, good evening everyone. This is Dr. Kamal Agrawal and I welcome to you the recall session of July 6 FMG. Now here I'm going to try to give you as close as possible to the question that you got in your session. I will try to explain you how to approach these questions, and this session is just not for those who attempted the session but also for those who is going to attempt in the future upcoming exam. I'll try to explain you each and every option and try to help you how to maneuver through different kind of questions. That's why I'm having multiple subjects recall right now. I may have not included all the questions in this video, so that's why you have to be patient enough. We'll include all the questions in the question bank of an LC. So I'll begin with my session. First of all, we will have biochemistry. Just just give me a cheers in the chat if you are able to hear me completely and you can see the screen properly. Yes, I already started getting answers in the chat. Okay, so I'll begin with the first question. Yeah, definitely, as we can see in the chat, someone has already answered that what is the diagnosis over here. This is none other than Leach-Nyhan syndrome. Now, the characteristic finding in this question that we have to remember is self-mutilation. Self-mutilation easily gives away the diagnosis, but as we know, it's a biochemistry question. They're gonna ask us about something underlying the pathology, and that is none other than HGPR test. So what is HGPR test? The full form is hypoxanthine guanine phosphoryl ribose transferase. Now you have to understand what is hypoxanthine and guanine. This enzyme is required in salvage pathway of purines. Purines is what DNA is made up of. Now, if this enzyme is defective, as we can see in Leach-Nyhan, what will happen to these both? These both will be converted into uric acid, and this will be the laboratory characteristic finding that written over here, hyperuricemia. You have to understand that these are the purine bases and they are recycled every time. They are very essential for the DNA synthesis process. Whatever cell that dies, its DNA material is recycled to make the new cell DNA. So this enzyme is used for recycling of the purine bases and nitrogenous bases present in the old cell. Other than that, the other options are xanthine oxidase. Now, this question is specifically asking about the deficient enzyme. But in case of xanthine oxidase, we know xanthine oxidase is also used to make uric acid. Okay, and not the deficiency, but the overactivity of xanthine oxidase is seen in gout. That's why the treatment that we give for gout is xanthine oxidase inhibitor, which is allopurinol. One very important thing that I want to tell you about allopurinol is the type of inhibition that it provides. It provides none other than suicide inhibition. Why it is called suicide inhibition? Because The substrate that activates it, it inhibits the substrate itself. So you have to remember it is an example of suicide inhibition. Other options are very easy. We all know homogeneous oxidase. The deficiency of homogeneous oxidase is none other than alkaptopenuria. The characteristic findings are blackening of nails, blackening of urine on long standing. And last is hexokinase. We all know hexokinase is the first enzyme required in glycolysis process. What use hexokinase is, it helps in trapping of glucose in the cell. How it traps? It makes glucose to glucose 6 phosphate, and due to this modification, the glucose will not be able to exit the cell and go into the bloodstream. Yes, trap glucose. Yeah, everybody is giving the right answers in the chat. Now moving on to the next question. I hope this question is clearly understandable and makes sense to you. Moving on to the next question. A chronic alcoholic patient came to your clinic having malnutrition. Always remember, the chronic alcoholic patient will have malnutrition and have lost considerable amount of weight. Which of the following process will be inhibited by alcohol in the liver? Now, to understand how alcohol is inhibiting any kind of enzymatic reaction in liver, we have to understand the simple basis of calorie relation in our body. Now you have to understand that whenever we take food, we provide some things in our body, and end product is calorie. Okay, whenever we eat food, food is converted into glucose. Okay, and then this glucose shifts the equilibrium of hormones from one side to another. Like in fat state, we will have insulin upon glucagon ratio high, which will favor glycogen synthesis. Now you have to understand, in chronic alcoholic patient, what happens? Alcohol is COH, it gets converted into aldehyde, and it gets converted into acid. Okay, in this process, what happens is we get NADH from NAD. Now what is this NADH? When we study glycolysis, when we study Krebs cycle, we know NADH give rise to 2.5 ATP. Okay, so we can understand that the patient who is consuming alcohol on a daily basis in a large amount, he is in a energy rich state. Now, if the body is already in an energy rich state, why it's going to make or do the process which is required for making energy? That's why you have to remember that gluconeogenesis is inhibited in chronic alcoholic patients. The inhibitors of gluconeogenesis are ATP, NADH. Okay, whenever a patient is having high amount of ATP or NADH in his body, gluconeogenesis will not take place. Also, this kind of energy, now patient is consuming alcohol, he is just having NADH, but he is not consuming anything in real. So these are known as empty calories. This glycolysis, for glycolysis and glycogenolysis, for glycolysis you need glucose. Patient is not consuming any kind of glucose. Okay, glycogenesis also, glycogen will only form afterwards when we have glucose, right? So it also requires glucose. So these two processes, it doesn't happen in a chronic alcoholic patient. So this is the clear explanation of why a chronic alcoholic patient is having gluconeogenesis inhibited in his body, because of this high NADH to NAD ratio. Moving on to the next question. Okay. If anything related to these questions or any topic that you want to understand, you can simply tell me in the chat and I'll explain it to you. That's why I already told you, this video is just not for those who already attempted the session, but also those who are going to attempt, so that you can understand that what you guys are going to deal with. Because learning and understanding the topics, you need to know what you are dealing with, how MCQs come in exam. So moving on to the next. Which of the following is the reason for using CRISPR? Now CRISPR This is a one-liner kind of question. If you have read this information, if you have came across this data, then you simply know this. CRISPR is none other than, you can remember, is CRISPR scissor. Okay? CRISPR is none other than scissor. It is a genetic scissor, molecular scissor. Earlier, to modify a gene, we have to replicate it, multiply it in laboratory settings many times, and then we used to get the desirable gene that we require. But now, after having developing the CRISPR technology, we can simply use these molecular scissors. It cuts one gene at a specific location that we require, and then attaches it to the other part, and the resulting DNA or the genetic material is made in a very fast and efficient manner. So which of the following reason for using CRISPR is gene editing. We edit gene with the help of CRISPR. For RNA repair, we don't have to remember the RNA repair in our curriculum. What about DNA repair? Now, DNA repair is a very important process because either it prokaryote or eukaryote, we all have cells multiplying DNA replication in our body, and we all know if DNA replication is not done correctly, then we can have certain malformations, certain diseases. So for DNA repair, either be it prokaryote or be it eukaryote. In prokaryote, we have DNA polymerase beta, which provides a DNA repair, and in prokaryote, it's 2, DNA polymerase 2. If you remember, the classification for DNA polymerase in prokaryote is 1, 2, 3, and for eukaryotes is alpha, beta, gamma, epsilon, theta. Okay, so for specifically repair part, I have told you it's beta for eukaryotes and 2 for prokaryotes. And then the last is the methylation. Methylation, let me tell you, methylation, there are certain terms that you have to remember. Methylation, methylation is there. Then we have phosphorylation. These both terms are related to deactivation. Okay, whenever DNA is methylated, that means this DNA or the genetic material is not going to take part in replication or coding. Whenever any enzyme is phosphorylated, that enzyme will not conduct the process, and it's in the deactivated state. You have to remember these two words. Okay. Now moving on to the next one. Hallmark, this is a very easy question. Hallmark for a vitamin A deficiency, it must, if it would have come with picture based, then also we could have understood, like a white color lesion in the cornea. It's simple Bitot spot. Okay, we can revise what are the others. Chiliosis is the breaking of skin around the mouth. It's seen in B2 deficiency. Okay, dermatitis, specifically dermatitis is a part of 4D syndrome, which include D. Okay, so it's dermatitis, it's dementia, it's death, and we can skip 1D. So it's specifically 3Ds of what? Pellagra, and pellagra is seen in deficiency of niacin. We have a subsequent question about this also, but it's good to remember everything at a single place. Either niacin can be deficient, or we know niacin is endogenously synthesized also from tryptophan. Okay, how much tryptophan we require to make one niacin? Can anybody tell how much tryptophan we need to make niacin? Okay, it was picture based. Yeah, even if it was picture based, then also we could have understood easily what is Bitot spot. And for burning foot syndrome, we have B5 or pantothenic acid. We need 60 mg of tryptophan to make 1 mg of niacin. Now moving on to next. Which of the following storage disorder will have maximum chances of presenting with cherry red spot without organomegaly? You have to remember that there are certain, we have glycogen storage disorder, we have lysosome storage disorder, and we have mucopolysaccharidosis. Okay, in these we have characteristic symptoms. For glycogen storage disorder, you know, either it's going to be liver related or it's going to be muscle related. In liver related, we have hypoglycemia, and in muscle related we have weakness or exercise intolerance. Okay, for lysosome storage diseases, we have two main characteristic symptoms, that is cherry red spot and organomegaly. For mucopolysaccharidosis, for example Hurler disease, Hunter disease, Sanfilippo disease, we have corneal clouding and also visceromegaly. So now we have to first, I will rule out the Hurler disease. Why? Hurler disease is a mucopolysaccharidosis. It is accumulation of aminoglycans in the body. Now Hurler disease is ruled out. We are left with Tay-Sachs, Neyman and Gaucher. So yes, answer is 1, Tay-Sachs disease. It's right, answer is Tay-Sachs disease, because Tay-Sachs disease is the disease which have cherry red spot but does not come with organomegaly. Which are the other lysosomal storage disorders which does not come with organomegaly? It's KFT. We have Krabbe, we have Fabry, and we have Tay-Sachs. Okay, Krabbe, Fabry and Tay-Sachs are the three lysosomal storage disorder which does not present with organomegaly. One of them does not present with cherry red spot, and that is in Gaucher. So that's why we are left with Tay-Sachs disease. Neyman disease present with both of them. It has cherry red spot also, it has organomegaly also. Other thing that we know about Neyman disease is zebra bodies. For Gaucher disease, we have crumbled tissue paper appearance. I hope you remember the enzymes deficient in them. It's good for your knowledge. Okay, moving on to the next question. I hope till now the questions are relatively easy. These questions are always easy, it's just the exam pressure is there. So you have to understand that the basics and the knowledge that you form while preparing for your exam should be strong enough so that they can withstand your own anxiety, because nobody is going to question you while you are in the exam hall. Only the person who's going to doubt on you is you yourself. So you have to practice enough so that you can have that confidence that yeah, I remember correctly, and this is the answer that I have recalled. Now this is image based question. We can see dermatitis, specifically where? In sun exposed area. So dermatitis in a sun exposed area near neck, we call it Casal's necklace. Okay, and which is the enzyme, which is the vitamin which is deficient in this case is niacin. In thiamine, yeah, I have remembered that there is a question related to thiamine deficiency also. It's every time exam is having that one question, either in the medicine department or in the biochemistry department. We can simply remember it by either it's going to be acute or chronic. Okay, for acute we have Wernicke's, and by the sound of chronic, for C for chronic and K for Korsakoff. So we have these both. Now we remember that Wernicke have GOA, GOA, that is global confusion, ataxia and ophthalmopathy. How ophthalmopathy comes here is nystagmus. Okay, what happens in an acute also happens in chronic, but with additional features. When the disease progress even more severely, earlier the cerebellum part has affected in the brain, so ataxia was there. Now the cerebral part is also affected, so the patient will have one very major characteristic finding in this chronic or Korsakoff syndrome, that is confabulation. Confabulation is false stories that we make to fill the gaps in the memory. because this patient is going to have retrograde amnesia, so he is not going to remember all the events of his life. So when the loved one or the dear ones ask about any previous memory, they fill up with any kind of information, and the relatives tell that they are telling more lie nowadays about the previous incidents. For biotin is specifically related to the hair metabolism, hair health. So the patient will have poor hair, he will have thin hair, and hair fall will be present. One thing you have to remember, biotin is something related to gym people, those who go gym, that consuming large amount of eggs on a large amount, consuming on a large amount inhibits biotin absorption because it has avidin. Always remember these kind of facts. Okay, so even if there was no niacin in the option, what other name we have for niacin? Either it can be given as NAD, it can be given as nicotinamide. Okay, if you are telling me that this picture was there or anything related to pellagra was there, and instead of niacin tryptophan was there, then I will assume that, as I already told you, tryptophan is necessary for endogenous synthesis of niacin. Any kind of deficiency in tryptophan, either tryptophan is deficient in the diet, patient is eating something that is deficient of tryptophan, or tryptophan absorption is decreased, or tryptophan consumption is increased. See, dietary take is decreased, either or absorption is decreased or consumption is increased. If patient is having low dietary tryptophan, that means he is specifically having high amount of sorghum in his diet. Remember, these patients consume large amount of sorghum. Okay, what disease we know about in which tryptophan absorption is decreased? That is Hartnup disease. And the only syndrome where we will see high amount of consumption of tryptophan, that all the tryptophan present in the patient body is consumed and none of them is left for formation of niacin, that is carcinoid syndrome. So okay, even if it was nicotinamide, it's straightforward. Then niacin is also given as NAD or nicotinamide. On the other hand, if it was tryptophan, or even if it's not, then it's for your learning basis that you can remember, tryptophan deficiency can also lead to pellagra-like symptoms. And how it can happen? Either of the three ways: low dietary, low absorption, or high consumption anywhere else in the body. So carcinoid syndrome. And I remember I have seen that there is a question related to carcinoid syndrome also, that the urinary level of 5-HIAA is elevated. So yeah, it will be related to carcinoid syndrome in the exam. And riboflavin, we already talked about angular stomatitis, cheilitis. We will see in riboflavin deficiency. Riboflavin, other name for riboflavin will be FAD. Maybe next time they will not give riboflavin, they will give FAD deficiency. So you have to remember that it is related to riboflavin. Okay. See, I can understand maybe the sense of the language of the question can be different, maybe some of the options can be different, but the main part, the clear-cut version of recall MCQs will be definitely uploaded on the question bank. For the time being, we are just here to help you go through the exam pattern and try to make you understand the basis of the MCQs, because one or two options can be different, I can understand, but ultimately the answer will be the same in any given scenario. Just like this, even if niacin is not given, it can be given as NAD or it can be given as nicotinamide. The answer will be same. Now next, this is a very basic question that we came across, the building unit or the subunit of the lactulose. Now, always remember there are two things: lactose or lactulose. Whenever anything having subunit of glucose, it will be ose, but if it replaced by fructose, it will be ulose. L will be added, plus L will be there for fructose. That's why if they asked about lactose, it would have been galactose plus glucose. But because they asked about lactulose, one additional L is there. That's why the answer was galactose plus fructose. Other than that, the other options were, if the other options were same, then answer they are glucose plus glucose is mannose. This is such a basic question that we all read so much of carbohydrate metabolism in biochemistry, but the initial first thing that they teach us about is the building blocks of the different kind of sugars in our body. So it's mannose, and there is nothing like glucose plus mannose, so it's just mannose. And one thing I want to specifically tell you about, the linkage in mannose is alpha 1,4. Okay, what if I change this linkage itself? If I make it 1,6 alpha 1,6, it becomes isomaltose. This kind of basic things also can always give you either marks or take away from you. So it's better to read some basic stuff also. It always helps in the exam. Okay, moving to the next question. It's last, yeah. So this is the last question for biochemistry from my side. Yeah, definitely there are other questions also in the session about biochemistry, but for me, I guess most of you have correctly answered them, and there was no problem about the questions. If any question that you know I didn't mention in the biochemistry section, you can simply tell me in the chat box and I'll discuss it. Now this question: an adolescent male present with mild icterus and loss of appetite. It was found that unconjugated bilirubinemia was with normal liver enzymes. So normal liver enzyme, that means there is no kind of insult is going on, like hepatitis is not there, alcohol syndrome is not there. So we are relieved by those. Okay. Now I'll mention the things that I have to pay attention to. First, second. These two things are very important for me. First of all, I'll see about the bilirubinemia. It's unconjugated. We all know bilirubinemia can be of unconjugated or conjugated. So this is unconjugated and the conjugated. Okay. Now adolescent male. I'll make newborn. I'll make adolescent, and then I'll make adult. Okay. Here you have to see, we are talking about unconjugated. We have conjugated also. First, let's divide them. It's doctor over here. In conjugated, we need doctor. Mean Dubin-Johnson and Rotor syndrome. So they are out of the question. Dubin-Johnson is gone, Rotor is gone. Okay. Now we are left with two more syndromes, two more options, and that is Crigler-Najjar and Gilbert. Okay. Newborn. Why I told you about the adolescent male? Because even if we want to differentiate between Crigler-Najjar and Gilbert syndrome, yeah, definitely there are two type of Crigler. One is one Crigler and Crigler-Najjar 1 and Crigler-Najjar 2. Okay. You have to understand that Crigler-Najjar 1 is the most severe type. Okay. But mild icterus is given over here, so definitely it's not Crigler type 1. What about Crigler type 2 and Gilbert? How we gonna differentiate between both of them? Because both of them have the mild symptoms. Yeah, deficiency is there, but they both are different parts. So that's where the adolescent part comes in. Crigler-Najjar always manifests in the newborns in the early age of the person, but Gilbert syndrome comes in the adolescent phase. It's a mild icterus, unconjugated by bilirubinemia, and in adolescent. That's why the answer over here is Gilbert syndrome. Yeah, they didn't mention about Crigler-Najjar type 1 or type 2, but yeah, we can simply rule out on the basis of severity also. Dubin-Johnson and Rotor are differentiated on the basis of conjugated bilirubinemia. The enzyme deficient in the unconjugated part is the single enzyme which helps in conjugation is UDP-GT. This enzyme is completely deficient in Crigler-Najjar type 1 and partially deficient in Crigler-Najjar type 2 and Gilbert. What about Dubin? Dubin we have MRP2 and Rotor we have ATP. Okay. So these are some information about the congenital bilirubinemia in biochemistry. It's also seen in pediatrics also. I don't know how we're gonna separate this MCQ in biochemistry or in pediatrics, but yeah, this is the basis we have to solve it with. Yes. Moving on to the next. So now we are back with forensic medicine. Yeah, forensic medicine was having quite enough questions, but most of them were the easy one. So first one is who conduct inquest. Inquest or kind of a important inquiry that is required in case of police custodial death. See, there are two types of inquest. One is police inquest and one is magistrate inquest. Okay. We are the main option that we have to take care of is like option A and option B. Yeah, lawyer is not there, coroner is not there. Okay. Now we have to think about two options. Either it's going to be higher police officer or judicial magistrate. If you want to easily rule it out, yeah, police will not inquest the police itself. Okay. Where we need judicial inquest? We need judicial inquest at A, B, C, D, E. Asylum, anywhere, death in asylum, death due to beating of police, death in custody of police, dowry death. Okay, dowry death which is less than 7 years of marriage, and last is exhumation. Exhumation is digging up the grave and taking out the remains of the dead one. If you need that kind of process to be happening in a case, then only judicial magistrate can order. And one more also, and that is F, that is death due to firing of police. So these are the specific reasons, and all of them are related to police itself. Death in asylum, death due to beating of police, in custody of police, dowry death less than 7 years, exhumation, and firing of police. So all these reasons, whenever they are mentioned, the answer will be judicial magistrate or judicial inquest. Okay. Higher police officer, when higher police officer is required to conduct an inquest in any unnatural cause of death, except these, any unnatural cause of death, higher police officer will conduct an inquest. Okay. Now moving on to the next question. If any kind of doubt is there, now there was judicial and executive magistrate in option. Still the answer will be judicial magistrate itself. Okay. Because this is related to judicial magistrate only. Moving on to the next question. So what is the permissible gestation age? Yeah, this MCQ is repeated so many times that we know on our fingertips. Okay, we have to remember that MTP can be till 20 weeks, till 24 weeks, and beyond 24 weeks. Okay, till 20 weeks, it's mainly due to contraceptive failure. Okay, till 24, it can be due to various reasons like rape victim, incest, when blood related siblings have coitus together and conceive, it's incest. Okay, and if it's dangerous for mother. So these are the specific reasons. Till 24 week we can conduct a MTP. What happens in case of more than 24 weeks? First of all, we need a medical board. We need a medical board with OBG, with pediatrics, with one state officer, gazette officer, and one radiologist. We need these four, and the main reason that we can perform an MTP beyond 24 weeks, because it's a very risky procedure for mother if we conduct that, and that is chromosomal anomaly or severe malformation. And to stay away from this kind of upper limit of MTP, that's why we recommend multiple type of scans in the whole OBG process, in the whole antenatal care process. One of them is specifically which is required for chromosomal anomaly is 18th week scan or target scan. Remember guys, that's how you can correlate all the integrated parts with each other. So the answer will be MTQ can in the failed contraception answer will be till 20 weeks. Sir, please tell me which. For the previous question, the answer will be judicial magistrate itself. Okay, answer will be judicial magistrate because the inquest that is required in this case is judicial magistrate. MTP question is clear. Exam was medium easy. We can call it that because now as we know exam is divided into two parts, first part and the second part, and now in subsections also. But you have to remember that 100% can't be easy, okay, but 85% is always manageable. Either it's moderate, it's easy, it's hard, it's always manageable. Now moving on to the next question. A patient died of fire in the house due to suffocation. There is fire, suffocation, inhaling a large amount of carbon monoxide. Which of the following post-mortem finding will be seen in this patient? It's post-mortem staining or the color changes to the skin happens after a patient died in a specific situation. We have to remember that because it helps a lot about the cause of death and the situation that the patient died in. For example, if you find a person body lying in grass somewhere and he is having a specific discoloration which happens due to a certain reason, you can understand that how the patient has died, and it can't be mimicked as a natural death. Okay, in case of carbon monoxide, you have to remember that the color that we will find in the patient will be cherry red color. Okay, now for example, if a patient died of suffocation in fire or something and someone tried to kill him by like that and then dispose the body somewhere else, then you can understand that this is not a natural death just by the color of the skin in the post-mortem finding. What about the other option? Bright red color. Bright red color or brick red color is seen in cyanide poisoning. Okay, cyanide also have one more thing that we have. Okay, try to remember as much as things that we remember of cyanide. Brick red color or bright red color will be seen in cyanide poisoning. Okay, it has bitter almond smell. Okay, what else it does? It does inhibit complex 4 of etc. Okay, so these are the enough required things that you can remember about cyanide. Brownish discoloration. Brownish discoloration is seen in many poisoning. Just to briefly tell you about, either it can be nitrite poisoning, it can be phosphorus poisoning. Okay, for blackish discoloration, you can simply remember it by opium poisoning, opium overdose. After that, if patient dies, the color of the patient's skin will be blackish discoloration. So this question was quite easy. It's just a straight factual question that you have to remember about. Yes. Now moving on to the next question. This is a very important question that you have to remember. It comes in forensic medicine also, it comes in pediatrics also, and it comes in surgery also, trauma part, and that is calculating the percentage of burn that a patient is suffering. A simple rule, we have to remember this person. Okay, he's having one arm. Okay, so the question is telling us that the right upper arm, the left upper arm, chest and abdomen, these three parts are burned in this case. Now I'll assume that both the front and the back part are involved in this case. Okay, so I'll give 9% for this arm. Okay, 9% for this arm, 9 for chest and 9 for abdomen. So 4 into 9%, I'll get 36%. Can you tell me if the question about this is completely right? That because I have seen multiple variants of this question from the student. Someone was telling me that only the right side was burned. Someone is telling is the right upper and the left upper and the chest and abdomen all are. But you have to remember that there are total 11. 9 is the rule of 9 or the rule of Wallace that you have to remember. Head and neck are 9%. Okay. Right arm complete front and back is 9%. Left arm is 9%. The upper chest is 9. Lower chest is 9. Then upper leg is 9. Lower leg and perineum is having 1. So if you count in total 1, 2, 3, 4, 5, 6, 7, 8, 9, and on the back side also the upper back and the lower back will have 2 more 9. So in total we have rule of Wallace or rule of 9 is having 11 9 in total plus 1% of perineum. So that's how we divided this. So according to this, the upper arm 9%, the right upper arm, the left upper arm is 9%, upper chest is 9 and lower abdomen is 9%. So 4 9 are there. So that's why we have 36% in the answer. Okay, moving on to the next question. This is a multiple time repeated question. It's a NEET PG repeat question and it's a very early finding. If you have read the post-mortem chapter in forensic medicine, you can remember that it is one of the early finding that we see in a post-mortem person. Now for eye we have two things that we have to remember about. Either it's going to be sclera or the retina. Both of the things are, first I'll tell you about tachinoire. The answer is tachinoire. As we can see, you can see wedge shape or triangle shaped lesion on both sides of the sclera. What is actually happening over here? When the patient dies and he dies with the eyes open, the eyes, as we know, when we blink, a film of tear is maintained. But if the patient is not blinking anymore and he died, so that film of tear will evaporate away. Now this sclera is being exposed to the environment and then there will be dust and other things. So this is none other than sclerotic changes plus some dust and other stuff on the sclera. Deposition of dust and resulting in sclerotic changes in sclera is known as tachinoire. Okay. The other thing that you have to remember, which is always given as an option in this type of question, is Kervokian sign. What is Kervokian sign? Now patient has died, there is no blood circulation, and due to that there is no blood supply in retinal veins also. So because of loss of blood supply to retina, there will be seen fragmentation of retinal veins. We call it Kervokian sign, or we can say cattle track sign. Okay, Kervokian sign or tachinoire. Cornea xerophthalmos. Xero word simply means dryness. So corneal dryness or corneal xerophthalmos is seen in vitamin A deficiency. We have already remembered that. Vitreous hemorrhage. Now for vitreous hemorrhage to happen, we need some kind of pathology resulting from retina. Either it can be in the case of trauma or it can be in the case of diabetic retinopathy or diabetic retinopathy, specifically in case of retinal detachment. Okay, so retinal detachment will be the cause of vitreous hemorrhage. For here the answer is tachinoire, which is the early post-mortem change in a dead patient. Now moving on to next question. Which of the following is the identical finding? Now as you can see how many times this particular image has been repeated. I hope this is the same image or the kind of image that you can easily understand. We see here there is a hand holding some vegetative stuff in its hand. Okay, now you have to understand one simple thing, that this characteristic thing, the patient was drowning or doing something and he grabbed something in his hand and then it stayed like that over there. You have to remember, you have to understand one very specific thing about this picture is that when he died, his hand stayed like that. There is no relaxation, or I want to say is absent primary relaxation. This one very important thing that you have to remember about this image, that patient died like this and it stayed like that. It didn't relax even for a single bit. That is absence of primary relaxation. Why I am telling this specific thing is because the thing that we have to differentiate it from, that is rigor mortis. It is a cadaveric spasm that we are talking about in this question. But the other thing that we have to talk about is rigor mortis, or the spasm when a patient dies. It's a sequential spasm that happens in all of the muscles of the body. What happens? How we differentiate it? By the absence of primary relaxation. In cadaveric spasm, there is no relaxation. Once the patient dies like this, the hand will stay like that until and unless we make it normal by the external force. But in rigor mortis, there will be primary relaxation, then there will be contraction, and then there will be secondary relaxation. So what are the options? Other options? Rigor mortis is spasm in a post-mortem person. Okay. One more thing that I can tell you about this cadaveric spasm is, this is antemortem. Patient made his hand like this before he died. Okay, it stays like that after, even if he dies, but this is an antemortem finding. Whatever spasm we are seeing in a patient who's initially he was relaxed, now his body is having spasms, it's rigor mortis, it's post-mortem finding. Okay, and what happens in the rigor mortis is, initially there was relaxation, suddenly there is contraction in the body. Now it goes away due to the secondary relaxation, and the reason for secondary relaxation in rigor mortis is proteolysis, because now the regulatory systems are not there, so all the muscles, proteins and the sarcomere, they start getting dissolved, so the patient will have secondary relaxation, which will also be seen in cadaveric spasm after the body starts rotting away. But the only thing which will really help you about is the absence of primary relaxation. What about the other two? Algor mortis. Algor mortis in simple terms is chilling or cold. What is cold? The body is getting cold. The normal temperature of a physiologic body is dropping every minute, every hour after the patient dies, because the regulatory systems are not there. So cold body. Remember, algor mortis is cold body. And for liver mortis is tanning, or other name, very popular name for this is sugillation. Now you can remember, see, if the patient is like this, okay, this is the table where we will see sugillation. We'll always see sugillation on the dependent parts. We'll see sugillation over here, occipital region, lower back, here around the feet, because after the patient dies, all the vessels in our body vasodilates. So now the blood flow will be according to the gravitational side, towards the gravity. So all the blood will settle down and it will give a characteristic coloring or the shade to the skin. That is known as liver mortis. Okay, yeah, some of the questions can that maybe you remember, maybe we don't remember. That's the main thing you have to understand about. There are some part that we have to give away for the recall. That some question can be different, some question can be there or not be there. But yeah, at the end we are trying to accumulate as much as information so that we can come as close as possible to the real exam and we can prepare accordingly. But all these topics till now we have clearly already discussed in class, and now also we are discussing. That's why I'm just not telling you the answer straight away that this is the cadaveric spasm. Okay, done, let's move ahead. What I want to is like that I'm again telling you, this session is definitely for those who attempted the session, but also definitely for those who are going to attempt this session, so that you can understand that just knowing the correct answer is required, nowadays the competition is so hard and everybody is trying so good that you have to remember each and every option, not just the correct answer but other options also, and when that option will be the answer. So that's why we over here are trying to explain you even the simplest thing so that it can be helped in the future exams also, in the upcoming FMG or the NEET PG, whatever exam you're going to come across. The basic fundamental thing that you require is the concept, because yeah, we can cram some stuff for a short period of time, but the concept stays away always. The concept doesn't matter according to the language of the exam or the question. Whatever the way examiner frames the question, the answer will be the same if the concept is correct. Okay. Moving on to the next. So now we come to ENT. For me, according to me, I guess ENT was on the easier side. ENT and biochemistry was on the easier side because not much questions were there. But yeah, this specifically question was framed in a different way. If you guys can tell me if the options are like this only, because yeah, I've seen so many kind of questions according to the autosclerosis, but this was on a different side. But yeah, it was easy enough, because if you remember what is autosclerosis, we all can answer easily about that. See, erosion with drum injury, erosion without drum injury. Erosion is never a part of any kind of procedure. At least in ENT, we don't relate to erosion in any sense. Yeah, ossicular fixation we have to do. What we specifically have to take. Yeah, thank you for paying attention in this session. It's a give and take situation for both of us. I can give motivation to you, and by attending these sessions and being actively participating in these kind of sessions and classes, it's a motivation for us also, because at the end of the day it's a teamwork that we are doing over here. Okay, now for the question, yeah, ossicular fixation. For autosclerosis, we all know this is a pathology related in which we can see spongioid. Normal lamellar bone is already there. Stapes is already there, which is a lamellar bone. Now, because of some reason, suddenly the lamellar bone starts changing into spongy bone. Okay, and it gets fixed into the oval window. And if it gets fixed in the oval window, what happens? That the conduction which happens through ossicles into the oval window, it gets hampered, and the patient will start having poor hearing. Firstly, the hearing that will get affected is conductive hearing loss. Okay. Other thing that we know as a one-liner for this pathology is either it can be Cahart's note, that 2000 dip. See, I'll make this is patient's conductive hearing. Okay, it's below. Here is the patient's sensory or bone conduction. Suddenly at 2000, there is a dip. 2000 hertz. This is not Cahart. Okay. Now, other thing we have to remember? This is the diagnosis part. That yeah, Cahart nose is there. Patient can be a pregnant female. Okay. The treatment part comes in play, which is usually the favorite part of the autosclerosis of the examiner. If the examiner gives you anything related to tympanic membrane finding that it's pink in color, or if examiner straight away tells you that SWOT sign is positive, then nothing we have to do, because the disease is in an active state. What we want to do is to make it mature, because if the disease is already in the active state, whatever procedure you perform, after some time the disease will take over that thing also. So again you have to reoperate. So we don't need that. First we need to mature the disease. We need to hold the process of the disease, and for that we give sodium fluoride. Okay. But in this case, autosclerosis, pregnant female. Initially, how we take care of is, if the patient is a pregnant female, first we wait for the patient to deliver the child. Okay, we usually don't operate in a pregnant female, but in this question, if the options were not mentioned according to that, still if we want to, then it will be ossicular fixation with intact tympanic membrane, because the pathology is not in any sense related to tympanic membrane, so we don't have to specifically do anything to the membrane itself. Okay, the only place that I remember that we have to do anything related to tympanic membrane to make an incision or do anything is SOM, serous otitis media, be it the serious one, be it the acute suppurative otitis media. When we need to drain, if there is any kind of fluid in the middle ear, then only we will go and touch the tympanic membrane. Other than that, we don't need to do anything to the tympanic membrane. So ossicular fixation with intact tympanic membrane will be the choice of treatment. One thing you have to remember is there is two procedures that we do. Either it's stapedectomy or otomy. Dectomy is, you can always remember, ectomy means to take it out. We remove the stapes, we put the piston. Or otomy is just making a window and then putting the piston over there. The complication that you can see in this case is fistula formation. Okay, fistula formation is problematic in this case because if the connection between the inner ear and the middle ear is through a fistula, then there is no regulation. The hearing will be hampered. So this question was easier side for the otosclerosis part. Okay. Now, moving on to the next. A child present to you with mouth breathing. His mother told that he has been performing poorly in school. On examination, temporal membrane was intact and the clear fluid with bubbles. See, this is characteristic finding straight away. Characteristic finding. If you see a bulging tympanic membrane with bubbles on the other side, that is serous otitis media. Okay. Now, which of the following management option will be present? First of all, see, child is having mouth breathing. Why a child is having mouth breathing? Maybe he is not able to breathe through his nose. Initially, the first thing that you should think about if a child is a mouth breather is adenoid hypertrophy. Okay. If there is any kind of infection or viral infection or cold and the child is having adenoid hypertrophy, then he'll start having mouth breathing. Okay. Now he is telling that poorly in school. Mouth breathing is not related in any sense related to the school performance. Why he is performing poorly in school? Because he is not able to hear correctly what his teacher are asking to him, and that's why he is being told that he is performing poorly. Why he is not able to hear? Because there is a serous fluid filled in his middle ear, which is hampering the conduction through the ear. So that's why I came to a diagnosis. Either I remember bubbles in tympanic membrane directly, serous otitis media, or I can go through the question and make my diagnosis. There is no pain, no red bulging tympanic membrane, so I am not thinking of ASOM. I am just sticking to serous otitis media, or known as glue ear. Okay. Now, adenectomy alone will not suffice because the fluid is already filled in the middle ear. Yeah, I will take out the adenoid and the breathing part will solve, but the fluid is already there. The hearing capacity of the child is already hampered. Antibiotic in this case is not required because it's serous. It's not suppurative. There is a difference between suppurative and serous. It's not infected, so I will not give antibiotic to the child. Only grommet insertion will take care of the hearing part. Whatever treatment I give to the ear part, till the time I do not take care of adenoid hypertrophy, the child will continue to have the symptom. So the answer will be adenoidectomy plus grommet insertion. Yes, you are right. This is the answer. One thing I want to tell you about, for serous otitis media, it can happen in child or it can happen in adult also. Okay. Child will have adenoid hypertrophy. One thing you have to remember about adenoid is it's in the midline. So in the midline, whenever hypertrophy happens, it blocks bilaterally east equation tube. So the patient will have bilateral SOM. What about adult? Usually adult have nasopharyngeal carcinoma, which is unilateral in presentation, and the patient will have SOM but unilateral. Remember this. Child will have adenoid hypertrophy, bilateral SOM. Adult will have unilateral SOM due to nasopharyngeal carcinoma. Okay, moving on to the next question. Which of the following is used for audiometric examination in case of a newborn? See, one thing I want to tell you about the audiometric examination in any case, that is, it is dependent on the patient itself. The patient report to you. For example, like Rene test, the Weber test. Whenever you do the tuning fork test on the patient tells you if he stopped hearing or not, which side he is hearing more. So that's why the main thing that you have to remember about in this case is that newborn is not going to tell you anything about this. So tympanometry, PTA, you have to remember that these tests will not directly help you in the case of audiometric examination in a newborn. The straight away answer for this is OAE or auto acoustic emission. There are outer hair cells in the organ of coating in the inner ear. Okay, these outer hair cells always produce some kind of emissions. We take a probe, we insert inside the ear canal of the patient. Now, if the patient is having these emissions, that means the organ of Corti or the hair cells of the organ of Corti are performing function correctly. So there is no kind of problem over there. The newborn is having okay. But if the probe is in external, okay, then there is middle ear, then there is inner ear. Here is the probe. If emissions are coming, it's all right. There is no problem. The child is not. If emissions are not coming, we are looking from the external perspective. We cannot clearly tell if it's middle ear or the inner ear. Okay. For that, we have to check for how to differentiate it from it with the help of BERA. If auto acoustic emission fails, we have to go with BERA. The full form of BERA we all know is brainstem evoked emissions, retrospective emissions. It have certain waves that forms whenever we stimulate. There are certain kind of probe that we have to put on the head and the neck of the newborn, and then we stimulate the brain of the patient, and then we see certain waves. These waves are nothing but the neurological waves or the neurons generating electrical activity. We record those activities and we try to understand which of the part are present. One very important thing that you have to remember of BERA is it helps to differentiate between cochlear and retrocochlear. It's a straightaway factual data that you have to remember, that there is no wave 2 in retrocochlear. Okay, there is no wave 2 in retrocochlear part. So that's how BERA helps us in this case. Now, for initially for audiometric examination in case of newborn, OAE is the choice because it's easy to do and it's readily available also. For screening part, OAE is there. If OAE fail, if we suspect anything, then we go for BERA. Okay, directly we do not go for BERA. Pure tympanometry is this. If you remember, this is the tympanometry. Okay, A. Then there is this, then there is B. These kind of graphs are there. Okay. Now moving on to the, which of the following is included in Grade-Ego triad? Now Grade-Ego triad, first we have to remember the diagnosis, that where we will see this triad. We see this triad in acute petrositis. Acute petrositis. Okay. Now, acute petrositis have involvement of cranial nerve 5 and 6. Straight away from the function of cranial number 5 and 6, we can remember. Cranial number 6 is LR6. Remember ocular muscles? We remember it like SO4, LR6. That is superior oblique is given by cranial number 4, and lateral rectus is given by cranial number 6. Okay, so the patient will have pathology related to LR6. Straight away we can see in 3 options diplopia, diplopia, diplopia. It's given. Now we're gonna take help from cranial number 5. Trigeminal nerve. Trigeminal nerve is a mixed nerve. It gives both sensory and motor. It has 3 divisions: ophthalmic, maxillary, and mandible. Okay. Now we have to understand if cranial number 5 is involved, there is some kind of pain will be stimulated in the patient. So one option and two options are having pain, but is trigeminal nerve is going to cause ear pain, any kind of referred pain? Whenever we read about referred pain, we don't hear about cranial number 5 in ear pain. So the answer over here is discharge. What discharge? Ear discharge. Deep retroorbital pain and diplopia. Garcinia triad has 3 D's. D, D, D. Discharge, deep pain, and diplopia. That's how you can remember Garcinia triad, which is seen in acute petrositis. Petrous part is the part of the temporal bone through which all the vestibular and the cochlear part takes exit from the cranium. So acute petrositis presents with Garcinia triad, which is discharge from ear, otorrhea, deep pain or retroocular pain behind the eyes, the patient will say is panic, and diplopia due to LR6 palsy, lateral rectus palsy. Now, which of the following is the staging method used for juvenile angiofibroma? Some told me that Radkovich was given, some told me Fitch was given. So yeah, answer is first Fitch or Radkovsky can also be the answer. Okay. TNM staging is specifically for all the cancers. We specifically don't do it for juvenile angiofibroma. Tumor size, lymph node involvement, and metastasis. So TNM can't be the answer. Ann Arbor. You have to remember, Ann Arbor is a very famous classification. We all study it in medicine, hematology. That is Hodgkin lymphoma. Okay, so this can't be the answer. And Duke's, in surgery we read Duke's classification or staging. Duke's staging, that is carcinoma rectum. So the answer is Fitch. You can easily exclude it by the other. Even if you didn't study about juvenile angiofibroma, you can give it by Ann Arbor and Duke. And TNM is a general staging. We do not do it specifically for juvenile angiofibroma. Now, which of the following vitamin deficiency leads to laryngemus stridus? See, stridus or stridor, it happens due to paralysis of vocal cord. Okay, any kind of paralysis or spasm or tetany of muscles is related to calcium. Okay, for calcium we specifically need vitamin D. Either it be the carpopedal syndrome, tetany of hands, or be it laryngismus stridus. We can simply tell it about vitamin D. Laryngismus stridus is seen in rickets patient. Okay. Other than that, vitamin A, we all know nyctalopia is seen. Okay, Bitot spot is seen. Vitamin K is hemorrhagic syndrome. Newborn hemorrhagic syndrome of newborn is seen. Vitamin C, we see scurvy, bleeding gums is seen. So this is the question. How it's easy to exclude also in this question. Most common, it was a picture based. The picture is not there anymore. Most common location for nasopharyngeal carcinoma, we all know it, fossa of Rosenmuller. Okay, fossa of Rosenmuller is there. See the image that I have seen that the students were telling was there for this is, it's like this. See, this is the opening. This is the eustachian tube opening. Here there is a swelling kind of a thing. This is torus tubaris. Eustachian tube. This is torus tubaris, and here this big structure is adenoid itself. So this middle part is fossa of Rosenmuller. I guess the way I have seen the image was, it was labeled as 2 over here, 1 over here, 3 and 4. So this kind of image was there, and the space over here in the 2. So the answer was 2. So fossa of Rosenmuller is the most common location for nasopharyngeal carcinoma. In which structure anterior ethmoidal cells drain into or open into? See, this is the nose of patient. This is the nasal septum. Superior meatus, turbinate, middle turbinate, inferior turbinate. Below each turbinate there is meatus. Okay, this is superior meatus, middle meatus, and inferior meatus. For superior, you remember PE, posterior ethmoidal cell. Okay. For middle, you remember anterior ethmoidal, middle ethmoidal, okay, and facial sinus, frontal sinus, and maxillary sinus. For inferior, remember nasolacrimal duct. So through this, the answer is anterior ethmoidal cells drain into middle meatus. Now moving on to the next, we have completed ENT. I hope whatever questions were included over here must have helped you on the understanding that did you correctly attempted it or not. And I tried to explain it as much as possible and as much as required at that moment. It's a easy session, it's a chill session. There is nothing to worry about anything right now. Just try to relax and try to understand the process itself. Okay. Now for the pedia. So it's a very important topic. The first question that is given over here is like fluid requirement in a new on the third day. So the classification that tells us about is according to it's according to the weight of the child. First of all, that is either it's going to be more than 1500 or less than 1500. Okay. Some books vary. Some books give a little bit of different kind of data. What I can tell you is for the day one, and then you can simply guess it on yourself. 60 to 70 ml per kg per day. It's required for a healthy or a normal, like for more than 15, not healthy, but for more than 1500 child, you need 60 to 70 ml per kg per day of fluid. On the other hand, if the child is less than 1500, this becomes 80 to 90 ml per kg per day. Okay, I told you about the first day. What you have to do for the subsequent day is plus 10 to 15 ml per kg per day for each day. So if we go for the higher limit like 90, so first day it's 90, second day is 105, third day it's going to be 120. Okay, so what is the fluid required for a newborn on third day if he weighs less than 1500 is 110 to 120. I hope these are as close as possible to the options, but I really don't understand if we can get all the correct options itself or not. But I am trying to tell you the correct method, correct way that you should have calculated this thing. Simply, I told you for a child more than 1500, 60 to 70 ml, less than 1500, 80 to 90 ml, and then whatever day you want to calculate, add 10 to 15 ml till the time day 7 you reach 150 ml per kg per day. That's the limit. That's the maximum that you have to go for a fluid requirement in a newborn. Okay. What will be the mid parental height for a male child? His father is 145, his mother is 159. Okay. Now I'll tell you the formula. I will not do the calculation completely because of the math. Mid parental height is father height plus mother height divided by 2. Now either it's going to be plus or it's going to be minus 6.5 centimeter depending on the gender. If it's male child, plus 6.5. If it's female child, minus 6.5. So around about it's going to be going to be 158 centimeter, 158.5 centimeter. Okay, you understand the formula: father height plus mother height upon 2. Whatever you get, either plus 6.5 it's the male child, minus 6.5 it's the female child. Okay, now let's move ahead. Whatever doubt, if anything that you want to understand about any kind of disease, or if you want to share any MCQ that you thought was there and I didn't mention in the particular subject, you can simply uh, message me in the chat box and I will discuss. Now moving on to the next. Which of the following: a baby was brought to your clinic on physical examination of notice he is having strong pulse on the upper lip but feeble pulse on the lower lip. See, this is the heart, this is the aorta, it's going. Subclavian will go from here. Okay, now something happens in this region. Here will be low BP, here will be high BP. Okay, one more thing, through this we also have arteries around ribs also, they also become like this. These are certain characteristic findings that I'm telling you about one particular disease, and that is coarctation of aorta. Because of this high blood pressure on the upper side, low blood pressure on the lower side, just because of this coarctation or narrowing of the aorta, give rise to certain characteristic findings. First, feeble pulse on the lower limbs, high pulse, strong pulse on the upper lip. Second, this tortuous vessels around ribs give the characteristic finding of rib notching on X-ray. Whenever we see X-ray of these kind of patients, we see rib notching. Okay, so the answer will be coarctation of aorta. Transposition of great arteries is a simple topic in which, as aorta takes place from left ventricle and pulmonary trunk takes place from right ventricle, it gets interchanged. Transposition of great arteries. There are two great arteries, they change their places with each other. So in this patient, the child will be having aorta will be supplied from right ventricle, which is deoxygenated blood. So deoxygenated blood, instead of going to lung and get oxygenated, it will go to the body and the patient will have cyanosis all over his body. What we see in this patient is, first of all, teratology of fallet and transposition of great arteries, both will have cyanosis. Okay, yes, this is coarctation of aorta. Both of them will have it will have cyanosis. There is no relation to strong pulse, feeble pulse. Okay, they will have cyanosis. Transposition of great arteries, on X-ray we will show egg on side appearance. Teratology of fallet will show boot shape heart. And for about PDA or patent ductus arteriosus, we will have machine murmur. Okay, so this is the question that we have completed. A child can walk on stairs with alternate step. See, on alternate step. His mother told that he loves to ride his tricycle, but he cannot come down of the stairs. He cannot come downstairs. He can go upstairs, but he cannot come downstairs and cannot hop the rope. What will be the approximate age? See, for coming downstairs and hopping the rope, we have 4 years. And simply the trick is, it's try, so I have remembered it's try for 3 years. Okay, for stairs alternate step, it's also a late third year milestone that the child reaches. So that means he's 3 or somewhat above from 3, but not 4 years till now. So the answer will be 3.5 years. Okay, moving into the next question. This is a characteristic X-ray that we come across many times. It just here you can clearly see one bubble, two bubble, three bubble. Okay, I can tell you about one bubble. It's pyloric stenosis. If we have two bubbles, it's duodenal atresia. And in case that we are dealing with over here is three bubbles, it's jejunal atresia. See how we are moving down in the GI tract from stomach, then duodenum, then jejunum. The bubbles are increasing. First bubble is stomach, then duodenum is also involved, two bubbles, then jejunum is also involved, three bubbles. If we see like this multiple fluid air level, then it will be short bowel obstruction. Short bowel obstruction. Okay, that is ileum is taking part. If these multiple air levels are in the center of the X-ray, they are escalating like this, and in the center of the X-ray, then it's small bowel obstruction. If there is a large bubble on the periphery, then it's the large bowel obstruction. Okay, so the answer will be jejunal atresia. CHIPS or congenital hypertrophic pyloric stenosis is seen in single bubble. Biliary atresia is not related to any kind of this pathology because we can't see biliary system on X-ray. So yeah, it's excluded from here. Okay. Now, fluid of choice for correcting dehydration in a child is there are if we have to talk about dehydration in a children, first of all we have to understand that how dehydration can happen in a person or in a children. What I suspect in this case is if they are telling me to correct dehydration in a child, yeah, we can give normal saline also, we can give ringal lactate also. But what came to my mind was if a child is suffering from dehydration, I have to suspect some kind of malnutrition also, some kind of deficiency also in this patient. So I will always add 5% dextrose in a child. You don't need to add 5% dextrose in an adult case because sometimes these adults can be having dehydration, but they can also be diabetic in nature. But in case of dehydration, always add 5% dextrose with ringal lactate. Definitely, in comparison to normal saline, ringal lactate have high amount of solutes, high amount of electrolytes, which will be more replenishing for the body. So if a child is suffering from dehydration, go with ringal lactate plus 5% dextrose. It's the best out of all the options. It's not like ringal lactate alone is not good, but if you see the text where the dehydration topic is being discussed in even in the standard textbooks, they tell you about the first thing they recommend is ringal lactate with 5% dextrose. Alone dextrose is of no use because it will simply not replenish the fluid. Okay, so ringal lactate plus 5%. Wasting in a child. See, either it can be malnutrition or it can be growth reduction. We have to certain use parameters in case of pediatrics to categorize the child. It can be either wasting or it can be either stunting. Okay, if you can simply understand by the name, wasting is related to the weight issue, but stunting is when the height or the stature of the child is compromised due to the long or prolonged or persistent malnutrition. Now for wasting is a child is defined as weight upon height. Okay, when a child is having low weight according to height, that means the height is growing properly, but suddenly he is having acute malnutrition. Sudden loss of weight is called wasting, and we always see this in acute malnutrition. Okay, so in acute case we see wasting, which is weight upon height. What about stunting? Stunting is when the height is not increasing properly according to the age of the child. And always remember, stunting is height upon age. Stunting is height upon age stunting, which resembles chronic malnutrition. Okay, For height upon weight, we don't need anything. Weight upon age is also a characteristic thing, and it's not directly used in pediatrics because we either use wasting or stunting, but you can call weight upon age as acute on chronic presentation. But in general, the bigger picture that you have to remember is wasting is losing of weight, which is usually a part of acute malnutrition. But if the height is not increasing properly according to the age, it's stunting, it's chronic malnutrition. And the last subject for today's evening is PSM. I know PSM is included. PSM is having a lot of questions, but I didn't include much of them because many of them were like straight away PYQs or the straightforward asking questions. I tried to make a easy kind of a recall session because yeah, there are many questions. I want you to have a gist of the paper right now, but if you want to clearly assess yourself according to the recall question that came in this attempt or the previous attempts also, you definitely should check out the question bank because the team over here is trying to collect as much as recall data from all the students so that the precise language of the question and the confusing option that usually comes in exam are being formulated right now. Here I have tried to cover somewhat all the departments of PSM so that we can have idea about the exam. Now the first question is straight away number based, like which is urban setup PHC. See, the thing about this question is if they asked about PSC in urban setup, suddenly the answer changes because see, there are sub-centers, there are PHCs, there are CHCs, okay, but when we go to the urban setup, the complete picture is different. Let me show you how it can happen. In urban setup, the minimum level that we start with is usha or urban asha. They are required to do from 25,000 to 2,500. Then the next step is A&M center. For A&M center, you have to remember they are taking care of 10,000 people. Next is PHCs. Okay, for PHC, urban PHC, it's 50,000. Other PHC that we remember is PHC can be hilly or plain. It's 20,000, it's 30,000. But in case of urban setup, PHC come under 50,000. So that's why just by mentioning urban setup, the answer completely changes and it goes to 50,000. Okay. For 20,000 and 30,000, PHC for hilly and plain area. TB online portal is directly Nikshay. Okay. Nischay in Hindi means to determine. What we want to determine is it's a kit that government is providing. It's a UPT kit or urine pregnancy test kit. It's for pregnancy. Okay. Now, what about these two options, dots and dots 99? I came across some students telling me that dots and dots 99 is also given. Dots is nothing but directly observable therapy. That because in TB cases, many patients, those who are having TB, they are poor people, lower socioeconomic people, they are not, compliant to the treatment. So we send a health worker and they directly observe the patient taking medicines every day. What about DOTS 99? DOTS 99 is a electronically IT enabled medicine pack that will help us to determine if the patient is taking medication every time. So DOTS is also a observable therapy. DOTS 99 is also, it just DOTS 99 is a IT enabled or software enabled kit which helps us to monitor the compliance of the patient. But the answer over here is Nikshay portal. This here you can see the IUD given in the choices. You can see it's like loops. It's none other than Lippe loop. It's first gen IUD. First gen IUDs are non-medicated IUDs. Vaginal sponge is usually like given like this. The usual question that we get from vaginal sponge is what it contains. It contains nonoxynol 9, nonox 9. Okay. Subdermal implants look like this sticks, which are placed subdermally. A cervical pessary. Cervical pessary is usually look like this. It's a cup-like thing that is inserted and put over the cervix. What is the ideal number of antenatal visits? See, this particular thing is very important over here that you have to remember. See, it's ideal, then it's minimum according to WHO and according to India. As you know, India is a developing country, and most of the things that WHO tells us about is about the developed country. So for ideal, it's 14 to 15 visits. For WHO, it's minimum 8, and for India, it's minimum 4. So what is the ideal number of visits? It's 14. Which of the following pneumoconiosis is caused by cotton? If it's caused by sugarcane, it's bagasosis. If it's caused by cotton, it's bicinosis. If it's caused in a coal mine worker, it's anthracosis. And the last one is if the patient is working in farm and moldy hay is being inhaled, moldy hay, it's farmer's lung. Okay. See, which of the following vitamins can be given to prevent the development of neural tube defect? It's a straight away question. This you can also remember from if you have remembered anemia Bharat. Okay, we give folic acid 3 months before the pregnancy. Then in first trimester also only the folic acid is given, and then we start iron, and that's because of vitamin B9. Vitamin B9 is required for differentiation and maturation of neural tubes and the CNS and the PNS in the body. That's why due to the deficiency of vitamin B12, B9, we face neural tube defect or spina bifida in the developing fetus. B1 again, vitamin B1 again that you have to remember, it's thiamine deficiency, wernicase or Proscoff. Vitamin D, either it can be in, if vitamin deficiency occur in child, it's rickets. In child, deficiency called rickets. In adults, it's called osteomalacia. Okay, and vitamin C already discussed scurvy. Now, a woman is having IUCD already placed, comes to a clinic with complaint of mild spotting, no complaints of pain. What will be the choice of management? See, whenever we insert a IUCD in a patient, the two main things that we have to think about is first, most commonly the patient presents with pain complaint, and pain is the most common reason for the removal of the IUCD. But also in case of spotting, if there is a spotting in case of patient, still we have to take care of that, and we have to remove the IUCD and let the symptoms subsidize, because maybe if we reassure the patient and send her home, maybe the bleeding will increase, any kind of infection is taking place. So main thing we have to take care of here is remove the IUCD, let the bleeding subsidize, check for any kind of other cause for bleeding if there. If not, if the patient is completely fine, then we can reinsert the IUCD. Now, heart of the activated sludge process. See, activated sludge process. What we are dealing here is waste management of sewage water. Sewage water is having this primary sedimentation tank, then this aeration tank, and then third is secondary sedimentation tank. Okay, here it takes anaerobically, here it takes aerobic. The largest amount, there are certain bacteria in sewage which we call coliform bacteria. Coliform are the one that we have to take care of, because those are the disease causing bacteria, and the main destruction or the reduction in the number of coliform bacteria takes place in the aeration tank. That's why heart of activated sludge process is aeration tank. 40% reduction in coliform 40% reduction in coliform takes place in aeration. From secondary sedimentation, it's just the two things. We take out the water. See, sludge is like this, and water comes up. Whatever the water in the secondary sedimentation tank is taken, it's taken out, it's chlorinated, and used for irrigation process. Whatever the solid material that's left in the secondary sedimentation, it's the manure. So the main process after which we can use whatever left behind is aeration tank, and this part here, aerobic destruction of the sewage takes place, which is activated sludge process, and aeration tank is the answer. What is the method which includes instilling people's mind with a particular idea, at the same time inhibiting their thought process? See, whenever we talk to the people, either we want to make them agree to what we believe, or we are just giving them a better thought process. There are two things that we have to differentiate in this. First one is health education, second one is health propaganda. Okay, propaganda is always attacking to the emotions. You are playing with the emotions of the person, and what you want is that a patient should have reflexive response. Reflexive response is without thinking. Now the patient will take decisions without even thinking because someone told him to do so. So here patient emotion is taken care of, not patient knowledge. Patient is having reflex actions. Patient do not think before taking decisions. Like in health matters, they are not taking any thinking about. So health propaganda is the answer. On the other hand, when we are taking about health education, we provide knowledge. We provide knowledge to the patient. We provide them the right guidance, and here the patient always thinks before taking the decision according to their health. Okay, so health awareness is simply demonstrating and telling about the prevalence of the diseases, how they can stay away from other diseases. And promotion is advertisements, writing slogans, and doing the posters, making things. But the main question over here was health education and propaganda. Education focuses on the knowledge of the patient, and patient thinks before taking decision. On the other hand, propaganda takes care of the emotion of the patient, and patient never thinks before the decision. He just takes it like a reflex. See, this is a question that I was very interested in. Some made it like gym owner told that those who come to gym and exercise also drink iced tea. One thing that I came across was this, that gym owner said iced tea is related to weight loss, or he said that the people those who are losing weight in his gym are because of iced tea. Now, how to till the time I don't get the exact frame of the question, I can simply explain you what we are dealing with over here. Okay, if someone is saying that iced tea helps you in losing weight, okay, instead of exercising, someone is putting it on that the people those who are coming and exercising in gym are losing weight because of iced tea. Then iced tea in any sense does not relate to weight loss. Okay, people those who are coming gym tends to drink more iced tea or any kind of caffeine tea or iced tea, but it doesn't help them to decrease the weight. So according to me, if you are telling me that the question was saying iced tea reduces the weight, then I will call it the spurious relation, because directly in nature there is no relation to iced tea helping lose the weight. Okay, but if you tell me that there are three things that we are taking care of. Okay, first is gym or exercising, second is weight loss. They are direct. Going gym, exercising and losing weight is direct, but they are also drinking iced tea. Now iced tea is related to gym also, iced tea is related to weight loss also. If it's the case, then the third variable, this is the first variable, this is the second variable, third variable which is related to both the effect and the outcome individually is known as none other than either confounder or indirect relation. Okay, then the indirect relation will be the answer. But according to me, in any sense, if someone is relating drinking iced tea to the weight loss, even if they are going to the gym, that means we are not considering going to the gym, and the main thing that we are focusing is like drinking iced tea is losing the weight. So for me, then it will be superior relation. In anything other than that, I would have I would have marked it as indirect. But in case of this scenario, when we are dealing with weight loss as the outcome, and we have to think about the exercising and iced tea, then I'll go with the superiors. And the last question for the evening is: a patient with edema over legs, heart failure, consuming food items, adulteration. Okay, see, either it can be paralytic patient, either it can be edema patient, okay, either it can be hepatotoxic patient or cirrhosis patient. Paralytic patient is seen in case of BOA or neuroletharism. Edema patient is seen in case of epidemic dropsy, which is due to sanguinarine. Hepatotoxicity is seen in patient who consume pyrrolizidine, or other name for is endemic ascites. And last one is cirrhosis. Cirrhosis in case of aflatoxin. Okay. So here edema over legs is given, and also heart failure. Plus there will be case of diarrhea also there. There will be presentation of glaucoma also there. Plus diarrhea. Plus glaucoma. Then the whole case revolves around sanguinarine. Okay, where sanguinarine is obtained from and what kind of adulteration is sanguinarine is obtained for? Argemone mexicana. It's a poisonous plant. People take the oil out of this plant and adulterate with mustard oil. Okay, so this is the thing that we have to remember. Sanguinarine is the answer for this question. I have given the presentation. If spastic paralytic of lower limb was given, then the BOA would have been answered. If edema is given, then epidemic dropsy. If patient is presenting with hepatotoxicity, pyrrolizidine is given, and last is cirrhosis. I can write the adulteration also is Khesari dal. This I have already told you. Argemone mexicana. Pyrrolizidine is Crotalaria seed. And last is aflatoxin. It's present in groundnut. Okay. For this, I have completed whatever question that I felt like should be discussed one-on-one with you through a video session. I have included in this session, and like I have already told you, team is already working on gathering as much as recall question for you guys, so that not just for the sake of those who have given the exam, but also because we as a team are always trying to come as close as to the real exam experience that you guys are facing over there. We are trying to understand the options, that how the options are really made for the exam, so that the confusion that you guys have over there can have a practice with us in this question bank series. Okay, for the time being, I hope you guys learned something today new, revised something that you already studied, gain some motivation for your upcoming exam, be it your FMG attempt, either it's the first attempt or the second attempt, or whosoever is going to pass this time and going to appear for NEET PG, this is the way that we have to go. The exam doesn't matter, the pattern is same in any case, MCQ pattern is going to come. So you should be prepared, you should be habitual of what you are going to prepare for. First thing that you need to do is to understand what you are preparing for. Directly going and start reading data will not help you, because there is overwhelming amount of data. What I want you guys to understand is, if I am solving any kind of MCQ, what's the approach and how much data that I have remembered about a certain topic. So try to concise and cater your or tailor your practice and your schedule, because time and syllabus is a fabric. You have to tailor it according to you, because everybody is different, everybody studies in a different pattern. I want you to have a precise idea about what you are dealing with and what you need to prepare for. And the last message that I want to tell you is, like, syllabus may be less or more, but the time is always enough. So don't think like you have less time or more time. It's always the enough time. You have to maintain the strategy that you are going to deal with. For today's session, that's it from my side. Thank you for being there and attending this session and paying attention. And this is me, Dr. Kamal. Thank you.